So I'm Ben. I'm one of the PGY4 urology residents, and I'll be discussing surgical ergonomics for the urologist. Hopefully, something that's pertinent to everybody here. Unfortunately, I do not have any disclosures to report. Although I am as one of the taller residents, I'm frequently asked if I want the bed raised, and often begrudgingly usually decline with the wish. So just a little background. So ergonomics is a scientific discipline concerned with understanding of interactions among humans and other elements of the system, and the profession that optimizes human well-being and overall system performance. Within that, there's physical ergonomics, cognitive ergonomics, organizational ergonomics. Today, we'll sort of be more focused on the physical, which is concerned with human anatomy and some of the anthropomorphic, physiological, and biomechanical characteristics as they relate to physical activity. So really, the study of ergonomics as we know it today is to optimize performance and minimize risk of injury to the user. Within urology and surgery as a whole, awareness is growing of the monumental burden of work-related injury. So work-related musculoskeletal injuries among surgeons are particularly prevalent, and most reports indicate about 2/3 of surgeons have some sort of generalized musculoskeletal pain. These injuries are often underreported, so making kind of research in this field and moving beyond the status quo quite difficult. Most reports indicate that only about 25 to 30% of surgeons report these injuries to their institutions. And workplace injuries might potentiate physician burnout, might shorten surgical careers, and they may affect surgical outcomes. And burnout, obviously, even amongst our own residents, something that we have much to be similar to concerned about. So there is when you're looking at different operative approaches, I think there's certainly differences in musculoskeletal injuries between them. For open surgery, surgeons are more likely to complain of neck, shoulder, and lower back pain, due to the increased working distance of the pelvis and the use of headlights or loops, which will increase cervical loading. For pure laparoscopy, they're more likely to report pain in the hands and wrists, as well as eye fatigue from looking at the screen. While use of a hand assist port can actually exacerbate the hand and wrist pain, even though it does actually help with the operation. There's nearly a full 4-fold increase in hand and wrist pain when compared to just pure lap. And for endourologic procedures, commonly associated with back and neck injuries, and obviously for this, the use of lead is a factor. Differences by surgical experience. So workplace injuries, as we know, have been known to be associated with prolonged awkward body motions or repetitive movements. We commonly conjure up images of a desk, someone working at a desk with a computer, carpal tunnel, but this is also prevalent in surgery as well. But interestingly enough, more experienced surgeons are less likely to experience musculoskeletal pain. And I think that actually only underscores the need for proper ergonomic education early in training to prevent development of some of these injuries. And just a couple of studies to highlight this. So higher volume of cases, actually is often associated with less pain. So this is a survey, 289 gynecologic surgeons who regularly practice robotic surgery. And respondents who had a higher robotic case volume reported significantly lower symptom rates compared to those with low case volume. So 34% in those with over 200 cases a year versus 60% with less than 50 cases per year. And these are actually, and what they found was that those with higher case volumes felt more confident in their surgical ergonomics. But these are we're not something. Yeah, these are not urologists, but there is some urologic data in the literature. So a survey of 241 laparoscopic urologists in China. These were less back, wrist, and hand discomfort in those who had performed over 250 laparoscopic cases than those who had performed over 250 cases, and these were statistically significant in these respondents. More years in practice is associated with less pain, associated with 200 laparoscopic urologists. For those who had been in practice for over 38 years versus less than 38 years, those who had more than 38 years had less finger numbness and eye strain than those who were practicing for less than 38 years. And then when you looked at sort of the newer laparoscopic surgeons, those who had greater than or less than 2 years of surgical experience, there again, less finger numbness and eye strain for those who have been in practice for more than 2 years versus less than 2 years. So how does this relate to urologists? So a survey of 165 urologists revealed that 90% experienced work-related pain, and 32% of people reported pain more than once a week over the previous year. About a third of these have contributed to this to awkward positioning in the OR, 15% for extended periods of standing, and almost 10% to attributed to equipment like loops, lay and lead. 6% for lifting and moving the patient. And most of these, most urologists actually just kind of push through. About 56% were able to work with minor or moderate discomfort, and a fair amount of people, the 30%, were able to work, just kind of push through with significant discomfort. What I thought was most interesting is that 8% required a leave of absence for, about a median of about 28 days. So, about 10% of people taking a month off work for their important injuries. Most people don't get ergonomic training. Only 17% of the respondents said that they had received training in ergonomics. But what's the cost of all these injuries? So nearly 10% of urologists saw corrective surgical therapy. This was, something as small as carpal tunnel release, all the way up to spinal fusion, rotator cuff repair. And burnt out surgeons reported more pain while performing surgery immediately after performing surgery. Obviously, pain is a hot topic. So I'm just going to go through some of the ergonomic considerations by surgical approaches. We'll do open, laparoscopic, robotic, and endourologic. I have to highlight these two papers, one out of Columbia, one out of Johns Hopkins for some of the visuals. So for open surgery, table height should be set such the surgeon's spine can remain upright, so back flexion of less than 15 degrees. Shoulder should be abducted no more than 30%. Elbow should be bent between 90 and 120 degrees. Your feet should be a hips width apart. Knees should not be locked. Kind of a big factor in musculoskeletal injury during open surgery is use of loops and headlamps, increased cervical loading, minimizing loop magnification using carbon fiber or stainless steel frames, incorporation of sort of through the lens, the loops, which I think most people have now, instead of the ones where you just flip them up and down. Can contribute to reduction in loop weight, and then that will actually reduce cervical muscle strain. As you see here, there's none. I don't think any of these three surgeons here are, doing proper posture here, and I'm sure the necks are very sore. So laparoscopic surgery does present unique ergonomic challenges when compared to open surgery. This is usually your range of motion is restricted. There's a fulcrum effect of laparoscopic instruments to fix abdominal ports, and hands and wrists are prone to excessive supination and ulnar deviation to grip instruments. Surgeon gaze is fixed on a monitor, which prevents free movement of the hand and neck while operating. This can result in neck and eye strain. So nice. What does that kind of look like? So optimal monitor position directly in front of the surgeon between 80 and 120 centimeters. So at a height at or just slightly below eye level, that limits kind of your neck flexion to 25 degrees. You shouldn't be having to move your eyes up or down, maybe over 15 degrees. Table should be about 70 to 80% of your elbow width. Your shoulder should be abducted, it should be abducted no more than 15 to 30 degrees. I know these are like kind of arbitrary, strange, nobody's got a protractor out and measuring their shoulder abduction or elbow bend, but it should be about 90 to 120 degrees. Just an example, here's a picture of, on the left here, this is table's too high, or the surgeon is not, surgeon is not standing on a step stool, and you can see obviously his shoulders are way too high. It's not a good, this is not a comfortable position to be operating in. And on the right, he's now standing on a step, surgeon's not standing on a step stool. Our shoulder height is at a more, and elbow height is at a more, and elbow bend is at a more appropriate angle. This is probably much more comfortable and less likely to result in shoulder or neck pain. So robotic assisted surgery has several ergonomic gains relative to the open laparoscopic approach. You have an adjustable seated operated position. You can have precise movement, very precise movements with the nervous articulation with minimal upper extremity exertion. The clutch control system allows for repositioning into sort of a more ergonomically favorable position while operating. And, the control mechanism really mimics the natural motion of the human hand. But you do have some physical discomfort that is still present, often secondary to prolonged sitting. And what does that kind of look like? So slight forward flexion, elbows bent again between 90 and 100 degrees. Should not be sort of neck flexion should not be more than less than 30 degrees. knees bent more than 90 degrees, and shoulder abduction less than 15 degrees. What I find interesting is that with the published literature about sort of how to sit at the Da Vinci, they do recommend a chair, which is a readily adjustable height, lumbar support, tiltable seat angle, parallel to the floor. But I don't really, so this is the Nightingale Da Vinci chair that they expect us to have, but this is actually the thing that we must have mostly in our OR. So, not exactly conforming to OSHA standards here. This is a nice visual. See here on the left, this is the eyepiece is too low. You notice the cervical, the back is a little too flexed, neck is too flexed. This is, as you see, the eyepiece, the headpiece is too high. You can see the back is arched, and then this right in the middle, much like Goldilocks and the Three Bears, it is just right. So endourologic surgery, many of the aforementioned recommendations for conventional laparoscopy can actually be applied to endoscopy, endourologic procedures, in particular flexible ureteroscopy. Display monitors directly in front of the surgeon between 15 to 30 degrees off the horizontal, at a distance of 80 to 120 centimeters. Table height should be adjusted that upper body is in a neutral position, shoulders relaxed, elbows bent between 90 and 120 degrees. And when possible, you should be seated to reduce muscle fatigue and strain on the lower extremities, and to avoid unilateral weight bearing when operating foot pedals. I find most of this, I think, stand anyway. This is actually not a picture of me operating, but this is a good depiction of what good posture while standing and sitting. So foot pedals for a laser should be aligned, and foot pedal for cautery is during 2 RVT should be aligned in the proper direction with the posture of the surgeon. Dorsiflexion should be limited to less than 25 degrees above the pedal. So the pedal should be locked in place to avoid shifting during the procedure. And for lead, 2-piece lead is better than 1-piece lead when it comes to reducing the rate of back and neck pain. So what can we do to prevent these musculoskeletal injuries? Exercise has been revealed to have a dose-related protective effect against pain. Regular exercise has been associated with reduced musculoskeletal discomfort in surgeons, and there's targeted exercising, some shoulder flexion extension exercises with slow lifting that have been shown to reduce neck and shoulder pain. Intraoperative microbreaks and preoperative sort of warm-ups before surgery, which is 2 things I'll probably get into, have also been shown to reduce musculoskeletal pain and surgeon performance. So microbreaks, quickly, so this was a study of 16 surgeons that were evaluated 3 times, once before surgery, which kind of served as a control, and these were surgeons across all different specialties, once after a common and reproducible 2-hour surgery, and once after the same procedure for which they took intraoperative microbreaks. So every 20 minutes, as you can see on the top right, they would sort of step away from the patient, and kind of stretch a little bit. They underwent sort of 3 different evaluations. They underwent a self-reported pain score on a scale from 1 to 100. They underwent a strength or fatigue test where they had to hold a 2.5 kilogram weight with the dominant arm fully extended. And then they underwent, it's called cut off, an accuracy test, which you see in the bottom left, where they had to sort of cut along the lines of this star shape with Metz and Baum scissors. And what did they find? That discomfort levels were lower after the procedure with microbreaks, that strength was greater with microbreaks, and that they're able to hold the weight for longer. And actually, they made fewer errors when cutting the outline of the star with the microbreaks. Obviously, not our highest level of evidence, but it's certainly something to consider. And now for warm-up. So this is an evaluation of 7 trainees that performed laparoscopic renal surgery. So 2 PGY3s, 2 PGY5s, and 3 fellows. So they had evaluation of cognitive, psychomotor, and technical performance during 2 different tasks, during mobilization of the colon and intracorporeal suturing and knot tying. So 4 total cases were done for each trainee. 2 cases were done following a warm-up, which was about 15 minutes of suturing using the box trainer and doing some VR and simulator exercises, and 2 cases without. And they found, and their cases were reported, reviewed by 2 blinded urologists for performance. They wore EMG under their surgical caps, so they could actually measure tension, drowsiness, and workload based on the EEG ratings. So they found that tension, those with the warm up were more attentive, less drowsy. Also found that their performance was better. They were smoother in their motions and had better posture. And overall, their performance was just better with warm up. And that kind of makes sense. Warming up is very, is kind of a staple of almost all activities that we do. And it caused me to do some self-reflection. And I sort of looked at from 10 years ago as a senior in college, where this was in the official Hopkins cross-country race warm-up, which is very, everything from an hour out of race time, including your bathroom time, was documented. And I was thinking about so before cross-country races, track races, I was basically already warmed up before the race even started. And then I considered what I do before the OR, which is just usually a caffeinated beverage. So definitely, I think something that I may change in my own, practice here. So in conclusion, musculoskeletal pain and long-term chronic injury, highly prevalent in the urologist workforce, increased rates of burnouts and shortened surgical careers, which can reduce hospital revenue and adversely affect surgical outcomes for patients. The need exists to prolong the career longevity of existing urologic providers by improving ergonomics in the OR. Principles of ergonomics should be incorporated into guidelines as well as residency education.
Jen, I know I just want to ask a question real quick. When you were doing this, did you come across any literature about how the instruments and the platforms are designed? Like they must be using some, like engineers, like when they're designing bathrooms, they have a very prototypical male and female that they're using, our architects, I mean. So is there something like that for surgical instruments as well?
So I know that is one of the things that I looked to improve, but I didn't really, that was kind of the focus of what I was.
One of the colorectal surgeons is extremely petite, and she has this whole thing. She does the robot. If you ever come across a robot that has a piece of like a towel that's been taped to the top of it, Dr. Manju was probably there before you, and because she just has found that she's just so tiny that it's just not. And instruments were not built for small hands either. We're on different sides of the spectrum, but yeah. So
they did that. I mean, there was in the paper basically the sort of like the guidelines for robotic use. So they were basically it's meant for like the 5th to 95th percentile. And they showed a picture of, I think, a surgeon who was 5'1" and at like the regular height, they were like feet were dangling, they couldn't even reach the pedals. And then they showed like the 6'6" surgeon who didn't really had to like really crane over just to get to the eyepiece. So I mean, I think for the extremes, it's a little tough, but I know that like kind of instrument design is something moving forward and really particularly focus my research and background.
And that's my experience also with the Da Vinci system, that I know it's a higher volume surgeons have less pain, but my neck pain is significant afterwards. And I try to adjust the vision, right? And it doesn't quite come to the level. But anyways, as the newer robots are coming out, that is one of the differentiators. For instance, Hugo has an open monitor, and you can basically stand straight up and operate with the monitor. So I think the additional robots are coming on that certain comfort, I think, is going to be one of the factors that manufacturers are marketing differentiate from the system.